Thank you so much for joining me for Chapter 16. We're going to discuss radioisotopes and how we're going to be able to optimize protection from these sometimes very dangerous materials. So we'll get started with our objectives. Today we're going to identify the most commonly used radioisotopes in imaging and in radiation therapy. We'll discuss the protection strategies utilized when using radioisotopes, and then I'm going to have you share the ways that radioisotopes are utilized in radioimmunotherapy, radiation therapy, nuclear medicine, PET and CT scanning, as well as in radioactive terrorism. So first of all, a quick discussion or quick recap of what an isotope is. Atoms of the same element always are going to have the same number of protons, but they can have variable, and most do have variable numbers of neutrons. And some numbers of neutrons are going to cause an atom to be very unstable. And so the atom, in order to stabilize itself, will start to eject either the protons or the neutrons to become a more stable state. When we have an isotope that is willing to do that, release those protons or neutrons to become more stabilized, we call that that particular isotope of an element radioactive, or we refer to it as a radionuclide. So to stabilize, radionuclides can be used in a lot of different imaging sciences, including nuclear medicine, PET scanning with CT. It can also be used in therapy to treat cancers. So we're going to talk about some of those a little bit more in depth, as well as some of those isotopes that work really well in those scenarios. So medical usage, one of the main medical uses of radioisotopes or radionuclides is that we know that when well oxygenated, rapidly dividing cells, such as those that really would be classified as a cancer or a malignancy, when they're exposed to high levels of radiation, oftentimes the radiation will kill those cells. So using radiation, as therapy, we'll typically use X-rays, gamma rays, or they can use protons or electrons to direct a very well-defined, collimated, very, very small laser-like beam to an area where the cancerous cells are available, they're well oxygenated, and we bring that radiation directly to the cell through radiation therapy to try and kill the cell. So the idea of radiation therapy is to use the damage we know is done by radiation to basically kill cancerous growths. In addition, radiation can actually be delivered internally to such regions by either infusion, where we're going to put an IV in the patient and infuse this radioactive substance into their body, or by implantation, where we're going to talk about shortly how they can actually implant radiation seeds into the prostate and let them emit that radiation over time, hence treating the prostate. Most isotopes have long half-lives, ranging from at least a couple days to years. And with the exception of just a few of them, most of them have a pretty high level of radiation. If you're going to go to the trouble of irradiating a patient, they're going to make sure that there's high enough radiation that they're going to cause the damage, hopefully just to the cancerous cells, in order to make it worth it. Radiation can be in the form of gamma rays or fast electrons or beta radiation. So looking a little farther into radiation therapy, some of the more important therapeutic radioisotopes that we're going to talk about. The first one is iodine-125. So iodine-125 is used quite extensively since the early 2000s, and what they do is they package these small amounts of iodine-125 into a titanium encapsulation, and then they actually insert these iodine-125 seeds into the prostate. From there, the iodine seeds do what they're supposed to do. They're going to be radionuclides, so they're going to be emitting radiation, trying to get themselves back to a more stable state. Well, if they're in the prostate and they're emitting that radiation should theoretically then be killing the cancerous cells within the prostate. So the treatment goal of this is to deliver about 145 gray to at least 90% of the prostate's volume. while limiting radiation to the other parts of the body, and as well as the urethra, bladder, all those close proximity organs. And so the idea of this is then, rather than maybe using a traditional radiation therapy where the beam would come from outside, go inside to the patient, that beam would have to travel through the patient's tissues to get to the prostate. This is basically putting the radiation inside of the patient so it gets emitted. Now, one of the considerations now is this patient has radioactive substance inside the patient, and so they will be exposed a little bit. They might expose family members a little bit, and so they really are a radioactive source, but the amount of radiation they're giving off is pretty limited. So when we look at iodine-125 specifically, it decays in a process called electron capture. So this is when we have a pretty unstable nucleus and we have an inner shell electron, and it gets attracted into the nucleus to attach to the proton, converting it to a neutron. So when that electron gets into the neutron, or excuse me, into the nucleus, it takes that proton, converts it to a neutron. Now I have a different number of protons, hence we're going to have a new element. So it won't be iodine-125 for very long. Now when it does that, it also has left a vacancy in that inner shell electron vacancy, and so we'll have an outer shell electron drop in, fill that inner shell electron vacancy, and release the characteristic X-ray on top of it. So we're going to have a couple different forms of how we are producing radiation in this case. So if you're around somebody that has this iodine-125, or maybe you're working with them, maybe you're taking them back to their room after a procedure. These procedures are usually done in an operating suite, and then the patient is usually allowed to leave the hospital that day, but they may be an inpatient for about 4 or 5 hours while they recover. So if you're working with these patients, you want to make sure that you are going to practice time, distance, and shielding. If you have somebody in your family with this, you want to be a little bit careful, especially early on, because you know that these radioisotopes are breaking down in that predictable half-life pattern. Here's an example of the 125. Here would be the iodine. Here, this would be the titanium covered seeds, and it's going to gradually be emitting that radiation from here. And then these would be all inserted with kind of like a needle-like structure inserted into the prostate for years often. Okay, another type of radiation therapy would be iodine-131. Iodine-131 has a half-life of 8 days. Now, the interesting thing about this one is very useful in that it can be compounded with the iodine with sodium. Now, one of the things that sodium, one of the organs in our body that attracts sodium is going to be the thyroid. It loves sodium iodide. So with what they'll do with this iodine-131, they'll attach it or compound it with the sodium, and then they'll typically inject it. Now, if the thyroid has a large uptake of sodium iodide, that radioisotope is going to be automatically attracted to go to the thyroid. So this is often used in patients that have had thyroid cancer and maybe part of their thyroid's removed, but they want to treat the rest of the thyroid that remains with some additional radiation. So in this particular case, they lace the iodine with something that is going to be attracted to the thyroid. That lacing material is going to deliver it basically to the thyroid, where it is going to be absorbed, and then it will sit there in that thyroid emitting its radiation, doing the radiation therapy internally outward. Usually this is rather than the seeds we just looked at, this would be in an oral capsule and the patient would take this. Again, the patient is going to be emitting some radiation, so the amount of time that they're maybe around, newborn babies, pregnant women, making sure that they're maintaining a distance that way can be important. This option works this type of radioactive decay works by beta decay, which is going to release X-rays and gamma rays. Now, those gamma rays are pretty high energy in this particular case, so those are the ones that are going to be most dangerous to, people working with these patients, as well as people that might be living with the patient when they go home. So, because there's some pretty dangerous substances out there in our radioisotope group of drugs. We have to be pretty carefully handling and disposing radioactive materials. So we must follow state and federal guidelines and regulations. Usually they're going to limit those that can handle these to people that are really specially trained in this area. So if you're a nuclear medicine tech or a radiation therapist trained with a particular drug, or maybe an oncology nurse or physician or medical physicist, those are really going to be the people that are going to be handling these. But just know that there's state and federal guidelines that they must follow. It's always encouraged that they wear gloves. They're going to have to wear dosimeters at all times, and that can even be an extremity dosimeter, like a ring on their hand, if they're handling things by hand. If there's leftover isotope after a procedure, that isotope has to be returned to a shielded container where it's going to need to sit for a minimum of 10 half-lives, and then it can be removed and disposed of with no special precautions. If by the use of a Geiger meter counter or a measurement of radiation, it proves that it's no higher than the background level, then you can dispose of it after that 10 lives. If it does not pass that test, it has to be returned to the shielded container again until it does pass that test. So another way that the nuclear medicine approaches we just talked about, those were to treat, it was a therapy to treat cancers. Now we're going to talk about nuclear medicine and how we can use it to identify pathologies. So one of the unique things about nuclear medicine is that it allows us to evaluate function of anatomy, whereas a lot of our other imaging modalities are really just looking at the normalcy of anatomic structure. So nuclear medicine is really useful in the way that it evaluates function. So nuclear medicine uses isotopes to study organ function in the patient, detect the spread of cancer, and treat certain types of diseases. Diagnostic techniques in nuclear medicine usually use short-lived radioisotopes. Now, when we're doing radiation therapy, we're wanting those longer-lived radioisotopes so they deliver the treatment over time. Here, with nuclear medicine imaging, they're going to want short half-lives. They're going to want that radiation out of their patient's system as quickly as possible. In order to do this, they also kind of like we talked about with the iodine-131, they're going to take these radioisotopes and they're going to attach them to molecules that are going to be attracted to certain organs in the body, and be able to study different organs that way. So one of the common radioisotopes used in nuclear medicine function studies would be iodine-123. Again, this is going to be compounded with sodium iodide, and remember that sodium iodide is very attractive to the thyroid. So when they inject this, typically, this would not be an oral pill usually as much as it would be an injection. When this is injected, it's going to travel up to the thyroid, and the really high functioning parts of the thyroid are going to take a lot of this up, and the parts of the thyroid that aren't functioning aren't going to take very much of this up. Well, because we have a radioactive emitting product in the thyroid, then they'll look at the patient under a gamma camera, which is going to assess the amount of radiation coming from the patient themselves, and that will tell them what the metabolism of that thyroid tissue would be. So here we would see hot spots or a lot of radioactive activity at that thyroid that was functioning well. If we had an area of the thyroid not functioning well, we might see a cold spot because it wouldn't be taking up any of that that sodium iodide. So this is very similar into the previous one we talked about, in that it delivers radioactive material to the thyroid. The only difference here is that was intended to stay long term and treat and destroy cancer cells in the thyroid. This one's just to show the function of the thyroid. Another and considered the most common type of radioisotope in nuclear medicine is technetium, and this is a really useful isotope because it binds very well with many different other compounds. So if, say, my spleen attracts sulfur, then they would basically lace sulfur with this technetium, and it would go to the spleen and demonstrate the metabolism of the splenic cells. So it's very commonly used because of that characteristic. So Technetium comes from the radioactive decay of molybdenum. So we've talked about molybdenum a lot as it relates to, you know, the anode or maybe a MAMO target or things like that. But in this particular case, this molybdenum-99 is considered a radioisotope. It does not have a comfortable number of protons and neutrons, so it does release radiation to get to that more neutral state. As it releases radiation, it releases a minimum, at least one proton. And as soon as it releases that proton, then we no longer have molybdenum, we have a new element, and that's going to be technetium. I'm not positive I'm saying that correctly, so forgive me. It has many uses, as I talked about, just because it's so easy to bind with other materials that will travel easily to organs. Okay, so that is just kind of another example of how we would use the nuclear medicine studies to image function. Now we're going to switch gears again, and we're going to talk about PET scanning. And then we're going to look at how PET scanning and CT can be fused in order to provide even more information. So the idea behind positron emission tomography or PET scanning really goes back to our photodisintegration. So when we have a photodisintegration event, as you may remember, we have a high energy photon coming in. And these are in the mega electron volts. High energy photon coming in. It comes very close to the nucleus. As it comes close to the nucleus, it transfers its energy into that nucleus and it simply disappears. We know energy doesn't disappear, but this particular photon appears to disappear because when that energy is transferred into that nucleus is going to kick out a positron and a negatron. A negatron is simply an electron. A positron would then be the opposite of the electron. So it would be the same size, it would be the same mass, it would just simply have a positive charge instead of a negative charge. Now this electron will typically go and it will, you know, find a vacancy where it can fill or do something useful. What'll happen is this positron is going to go off and it is eventually going to come in contact with another electron. When this happens, it's going to go through annihilation, and it is going to have basically annihilate these two components and shoot them back in the direction for which they came at an energy of 511 kiloelectron volts, which if we think that 120 keV is high, this is 511 kiloelectron volts. So that's the interaction. Basically what they'll do is they'll inject something or get something into a patient that they know is going to be able to have this type of interaction. And they'll usually attach it to something, again, that's going to be attracted to one of your organs. And when the organ, lots of times one of the things they'll use is they'll attach this material that's going to promote a photoannihilation. They'll attach that material to glucose. Well, we know that glucose is something that cells like to break down, especially if they need energy fast. Well, one of the things about cancer is that cancer cells have a really high metabolism. They're multiplying very quickly. They're not stopping. They need a lot of energy fast, and so they're going to have a large glucose uptake. So what happens here with PET is this photoannihilation energy is taken, attached to glucose. Glucose goes to the high metabolic areas within the body, and then it has these interactions where we will have this annihilation event where eventually that electron and that positron will annihilate each other, shooting energy out directly away from each other. Now, be outside of this patient, they're in something that looks kind of like a gantry of a CT machine, and it has detectors all the way around. So every time that these events occur, it's going to shoot a photon, get attracted by the detector, and that detector is going to be able to evaluate these areas of really high metabolism within the patient. So now the PET scanning, that is going to tell us where there's high metabolism, and it's going to provide some functional information. But when they group a PET and a CT scanner together and they combine it into a singular piece of equipment, they can have that PET detection along with the imaging from the CT so that we can see exactly the anatomy that those high metabolic rates are occurring at. So the most commonly type of radionuclide used in PET and CT is going to be fluorine 18. This also really attaches well with glucose, and so that's why this is a good material for this particular type of study. So here's an example. You can almost see this would, one of these rings would be the detector of the PET scanner, with the second ring being the detector of the CT scanner. So you're getting that metabolic information, and then you're superimposing it over the imaging information. All right, now there are some really unique and kind of challenging aspects of PET and CT. So some of the considerations are that they are doing injections into these patients of radiation that has the ability to have very, very high energies of up to like 511, or specifically 511 kiloelectron volts. And so we know that energies being released by that patient out around them are going to be very penetrable. So the design of the rooms for these studies and these types of procedures need to be really specific in order to protect workers and other people in the hospital safe from that level of radiation. So not only do we have the patient with these radioisotopes emitting a ton of radiation, but then we have the normal scatter produced by the CT portion as well. The presence of patient prep time, where they usually will inject these patients and then have them sit for 20, 30, 40 minutes for the uptake, the glucose uptake to occur throughout their body. That means they're sitting there emitting radiation all of that time. So not only do you have the radiation in the actual imaging room, but you have the radiation in the prep room as well. That would mean that these rooms would have to be very well lead lined. In fact, for 511 keV photons, it takes about 5 centimeters or 2 inches of lead to serve as a half layer. So it's not very realistic to lead line all your walls with more than 2 inches of lead for these procedures. So they have to do things like work hours and rotating technologists and different things like that, which will help reduce overall patient dose to people. Here's just an example of some of the things that they have to really think, and you really need an expert to design these rooms. So this would be a prep room. This patient would be emitting radiation while they sat here. Here would be the PET and CT scanner. They'll be emitting a lot of radiation while they sit here. Here's the hot lab. This is where those radioisotopes are going to be mixed. So there's a lot of different highly emitting radiation all around this area. So they have to make sure that they are doing appropriate lead lining on the walls where necessary. Okay, and lastly, in a completely new process, we'll talk about nothing to do with our patient care, nothing to do with treatment or bettering a patient's life, but we have to look at radiation emergencies and how radiation can be utilized as a terrorist weapon. Most hospitals have radiation emergency plans for handling emergency situations requiring or involving radioactive contamination. The radiologic technologist should become aware of these plans and help implicitly with the situation if it ever becomes necessary. Oh, I'm sorry, that slide was out of order. Really quick before we go into that, however, I do want to talk about radioimmunotherapy. So we know that if we're talking just about our immune system, that we have our immune system's purpose is to provide protection from infection. So we have things called antigens. Antigens are proteins that are not recognized by our bodies as being supposed to be there. So when I have an antigen, my body says, wait a minute, something is here that shouldn't be here. Then my body has antibodies. My antibodies are part of my immune system, and they are going to go and they are going to try to attack the antigens and keep everything that shouldn't be in my body out of my body. There's a specific type of antibodies called monoclonal. Monoclonal, look at the part of the word here. Mono is one and clonal would refer to clones. So monoclonal antibodies are antibodies that all look exactly alike. They look like clones together, and they come from one stem, one ancestor cell. So they're all going to look exactly alike, and they're going to become really important when we talk about radioimmunotherapy. And then on top of that, we have our pathogens. So antigens would be anything that is recognized as an invader of our body. Now, a pathogen would be something like more specific. It would be a bacteria, a virus, a parasite. Those would fall under the categories of pathogens. So these are just some important terms to know when we're talking about our immune system. So really, we have antigens or pathogens that get into our body. Our antibodies react and they go and they try to address those, and that is how we hopefully maintain homeostasis. Now, we can utilize our immunity with something called radioimmunotherapy. And so the smart scientists have discovered that there are certain antibodies, specifically monoclonal antibodies, in which can be trained to recognize and bind to certain proteins on the surface of cancer cells. So they will be specifically shaped to bind to specific proteins that just happen to be on cancer cells. So what they're doing then is they're using these antibodies as like a delivery boy, so they can lace the antibody or label it with a radionuclide or a radioactive material. That antibody then delivers that radioactive material, and as it decays, it's going to release that radiation directly to the cancer cell and hopefully destroy it. So it's a really efficient approach in getting the radiation to the cell. The unique issue here would be that cancer cell has to have a unique protein that's not on any other of the healthy cells, or my antibodies would be delivering these little radioactive treatments to good and bad cells. So it's really important, and not all cells are going to fall into that category. So radioimmunotherapy is going to be dependent on the type of cancer and what exactly it looks like on a cellular level. The other thing that can happen is they can also, they have the antibody, which is going to deliver the radiation. The other thing that they can do is they can lace that antibody with a second type of radiation, one that's going to treat and one that's going to emit radiation that can be picked up by a gamma camera, so that it can see where the treatment is being delivered to. Okay, now back to radiation emergencies. So the term contamination is really important. This is when we're contaminated with radiation. The radiation exposes us, and then we have to figure out how to clean this up in a safe, effective manner. So the radioactive dispersal device, where they are emitting radiation through as a terrorist weapon, is typically called a dirty bomb. A bomb would just be a conventional explosive. A dirty bomb is a conventional explosive with radiation in it. So the idea is intended to contaminate an area with not just the dangers of an explosion, but with the dangers of radiation as well, and therefore causing extensive panic. Now, the radiation is monitored with Geiger-Müller detectors, which will give levels of radiation. Now, depending on the levels of radiation, you know all the reasons why because of our previous lectures and readings, but you know that long-term health effects are going to be dependent on exactly how much radiation is released in one of these types of attacks. So if contamination was the emission of radiation onto something, decontamination would be the removal of that contamination. So first part of decontamination would be removal of contaminated clothing and storage in an area where where that radiation cannot continue to be emitted. So in a basin, in a lead locker, and something like that. Immersion in a shower is going to be important in washing radiation off of the body, making sure that wounds having any radioactive material are thoroughly cleaned. And then lots of times just rinsing the area will be sufficient to get a lot of the radiation off of a victim. You can use a Geiger-Müller detector or counter to detect how much radiation is still on a person or in their clothes or in other areas to see how efficient that removal of radiation has been. Now, anytime the radiation has been on you, you've already been exposed. So the importance of getting it off of you will just not stop what's already been done, but prevent more damage from having that longer term exposure. The Environmental Protection Agency is responsible for kind of some of the guidelines when it comes to what we do in radiation emergencies. And for individuals engaged in non-life-saving activities, they place a limit of 50 millisieverts on the person. So if you were doing something helpful but non-life-saving, maybe moving dirt around or something else to help with something that wasn't urgent, to help with the decontamination or cleanup, they would, once you hit 50 millisieverts, they would ask you to discontinue your work until further notice. For individuals that are engaged in life-saving activities where they're going and rescuing people, treating people directly, they give them a little higher, or a lot higher really, effective dose limit, which would be 250 millisieverts before they would pull them. If a dose rate is greater than 0.1 millisievert per hour in an area, emergency personnel should wait until the dose decreases to proceed. So they would be asked to not perform any duties at all until that dose was lower. Cleaning up a contaminated urban area, because it's urban, we have a lot more people around, there's a lot more risk, a lot more people to be affected. The risk limits for radioactive contamination are set by the EPA, and it's going to come depending on the urban area, how much population there is, what's the geography. All of that is going to be very complicated and be important considerations in the cleanup efforts. Medical management of persons experiencing radiation bioeffects is going to be very challenging if they were exposed to those whole body doses that are large enough to cause acute radiation syndromes. The first thing that you'd want to do is surface contamination or decontamination procedures, get them cleaned up, try to prevent any further damage from being done. And then dealing with the patients with that acute radiation syndrome, it's going to depend on their levels. Some of them might be susceptible to having treatments and seeing some improvement, especially if they're only affected in the hematopoietic syndrome or maybe the gastrointestinal syndrome. If they're higher than, if they're in the more significant syndromes than that, then probably palliative care is going to be the goal. So here's an example, and I know we kind of talked about this when we talked about those acute syndromes initially, but you'll see once we're getting to that whole body dose of 1 gray, that's where you can start seeing some of that, some of the the blood, the acute blood syndrome. When we get to down here in 4, that's where 4 or 5, that's where you're going to start seeing that gastrointestinal syndrome. When we're getting up to 10, that's when you're going to be into additional syndromes, and then finally CNS is going to be at your 50 level. So there's a lot that the the patients are going to be going through at that time, and having an understanding of your acute whole body radiation doses and expectations are going to be important in being able to be available to help. Okay, so in summary, radioisotopes are atoms that release protons, neutrons, or other subatomic particles to become more stable. Radioisotopes are used in imaging and in treatments. They can release high doses of radiation and must be handled appropriately. And the threat of use of radioisotopes for terrorism is a concerning possibility. So thank you for spending this time with me, and I hope you have a wonderful rest of your week.